I want to talk to you about incorporating the RETeval into the patient flow and making it part of your examination. I want to talk to you briefly about steps for delivery, especially in a new practice. Who we choose in the practice to learn to do the ERG and why. And also a few discussions on the ease of the use of its interface, because when I did look at it for the first time, I was a little bit puzzled. I was curious how it was going to operate, how quickly I was going to be able to program and move in between the patients. And with just a minor amount of a learning curve, I've learned to adapt these into our patient regimen very, very easily. We received our first RETeval in May of 2017. We began doing the 28 Hertz flicker studies and the diabetic retinopathy screening studies almost immediately. We've done a few VEP studies in some of our dry age-related macular degeneration patients. Because we first incorporated it in May of 2017, this is just a breakdown of how many scans we've done in our office in just a little under 2 years. In 2017, we did 227 patients. 2018, a full year, we did 286 patients. In 2019, between January of 2019 and just October 8th, we've already performed 163. So we've incorporated over 675 scans into our vitreoretinal practice at Island Retina. Okay? So we are a fully functioning retinal practice in which the patient has to come in, of course, through registration. They have to go through an initial testing and a full medical interview by our medical staff, which includes visual acuity testing, dilation, testing for glaucoma. And then after that, now I'm talking about a new patient examination, the patient has to be examined by Dr. Weber. And then special testing takes place in which we, in the imaging department, have to verify her suspicions. Then the patient goes back to Dr. Weber, where she begins a discussion about what we've imaged in the imaging department at Island Retina and what her suspicion is and where she wants to go there for either further treatment or a follow-up examination. So that is part of a full first examination as part of a dilated retinal exam in a retinal practice. If she feels that the patient needs an ERG, RETeval ERG, she will schedule it in the next follow-up examination, and it will be written in our discharge summary. So when the patient comes back, all right, after visit 1 is over, when the patient comes back for visit 2, that is when the ERG will be scheduled. Now, of course, we all know that it has to be scheduled before the patient is dilated, because the RETeval also tests the pupillary response. It is part of the primary control of the device in order for it to complete the cycle successfully. We, the operators, in a darkened room, have to make sure that we have the patient's undilated pupil within our sights the entire time. So, like I was saying, this happens in the subsequent visits to our practice, and it is very clearly labeled from the secretarial staff to the intermediary staff to the person who's doing the visual acuity testing that this patient is going to have an ERG as part of this visit. And quite simply, after the visual acuity is performed, an ETDRS visual acuity is performed and recorded. At that point is when we start the ERG preparation of the patient. A patient's intraocular pressure can be measured easily because it only requires a drop of 0.5% tetracaine. And then, of course, we have a contact tonometer in our office. But dilation drops are not added. Okay? We immediately perform the flicker ERG. And that takes place in a darkened room. Of course, you all know the parameters. You can have a gentle illumination of what we call the dark room light. We have a red lamp in a completely dark room. We have the room completely devoid of all white light stimuli. We teach the patient what we would like to have done. All right? And then we perform it, of course, preparing the patient accurately, connecting the patient accurately, performing the flicker ERG on the right eye in the dark, and then the left eye on the dark. And then we can dilate the patient. We can continue with a dilated examination because we are a retina practice, and Dr. Weber does need to do a phenotypic examination of the retina. We also then begin to plan our further studies, such as fluorescein angiography studies or optical coherence tomography studies or an ultra-wide field OPTOS image. Okay? So, important to know, do the visual acuity, perform the flicker ERG, then dilate the patient, and then the patient can continue with the remainder of the retinal exam. Okay, so who does this part of the flicker ERG at our office? Well, it's someone that is not the visual acuity testing person. It can be her, but if she's the one that is performing it, she can't go on to see the next patient that we have scheduled. So it becomes part of the responsibility of the imaging department. We have some very specially trained personnel. So it can be a visual acuity technician. It can be a scribe. It can be the imaging personnel like myself, or the photography of the other technician like our other staff. But what's most important is that it should have some computer interface knowledge or some computer interface skill. Because as we all know, we return the RETeval to the base cradle. What's the first thing it's going to do? It's going to pop up. It's going to show you the results. And the person has to be comfortable with knowing to either going for the raw data form in case the RETeval is being used for a national study, or to go to the results page, of which you all know a PDF is generated, and that can be very easily incorporated into the examination. Again, the ERG results are immediate, and impress that. They should know, like, oh, how long do I have to wait until I see the result? Well, the result is actually in their hand. As soon as it gets returned to the cradle, and the cradle is plugged into a computer that's part of your network, it can immediately be loaded, all right? The ERG is always compared to a normative database, and in ours, we of course look at the diabetic retinopathy assessment, okay? That report page is very easily loadable into almost all electronic medical record programs. And that report page is also something that can be sent off to a referring physician who's asking about the progress of their patient. So it's useful in those two modalities. In our EMR, we upload it into the record as a visual document. All right, we leave a little space in the imaging section where we can write a manual report about the flicker result, either its implicit time, all right, or its duration, the time, the date, and we can move on from there. It's very, very friendly to use. It's portable, which is great. I don't know if you know this, but it only weighs 8.8 ounces. A cell phone weighs, I did a comparison weight on our scale. An iPhone XR weighs 10.2. So it's actually even lighter than your iPhone. Okay? You can be easily incorporated into the office. It can be easily transported between offices as long as the interface cable is available, and it can be plugged into a server that speaks to your client's EMR. This is non-dilated testing, 55 seconds per eye. That's all it takes. And the results that they get are incredibly, incredibly useful. The way Quentin thinks about electronic signals is because of my training and my background in clinical ophthalmology and in research in ophthalmology. I also think about those kinds of interactions and cellular changes the same way he does. Not very many imaging specialists or technicians think that way, but I think that way. And I take this very, very seriously. I've answered many, many questions about ERG testing. And lastly, it is very, very helpful for following the progression of disease.